So basically we'll look at just four quick things: technical, hardware, arithmeology, and futuristic. Now if you see technical, size of the ICD, physio curve shape of ICD, and subcutaneous ICD. We all know size, I don't have to tell you. We started from 280 grams and now we have come to 70, and it is going to be a miniature experience as time goes by. Bio shape is important. Now it is for better cosmetics, less erosions, wearing comfort. The whole thing has shifted from horizontal to a vertical orientation, and that is because of that, the header and the lead and the coil, you get less fractures because of that. So that's bio shape is important, and of course DF4 connections now, instead of 3, it's all single sensing, pacing, and defibrillation. So this is what the bio shape has made a difference. We all know subcutaneous ICD, subcutaneous with the lead in the over the magnum sterni. The only thing we must know is that yes, the conventional versus the subcutaneous, it's a great advance. But we must know there are going to be limitations. The advantages are, obviously there is nothing intravascular, no problems with later on endovascular lead extraction, less fluoroscopy, and of course aesthetic people are, there is nothing from the subclavian side. The thing we must know is where you should not put a subcutaneous ICD. And that is, of course, when there was there's need for pacing, when there is need for a CRT device, and of course you cannot have ATP for conversion. So when you have these 3 criteria, then you should not go for a subcutaneous ICD. Hardware, simple MRI compatibility, battery longevity, improvements in circuit components, and of course all elements. So all these are basically to improve the efficacy and avoid complications of ICD. MRI compatibility, now basically when you say MRI, it is, you must know this, it is called MRI conditional. MRI conditional devices, not MRI compatible devices. It's a common thing in our part, people call it compatible means people think you can do anything. So what has changed is basically in this, now whenever patient goes for MRI, it goes to a VO mode automatically. You don't have to reset it now. But after the MRI is over, it's a time-based MRI exit time. That means after 6 to 9 hours, the patient, the MRI will actually reset back into its original mode. The problem is, why do you still require to interrogate? Because still for safety of the lead, sometimes rarely we have seen that the impedance goes haywire, and that is why we still have a check after the MRI. But otherwise, technically today you don't require, because it has an exit mode, number 1. And number 2, the second advance is that now if you have a CRT-D, then the bi-V pacing mode is still maintained in a current generation MRIs, which was not there previously. So this is as far as the MRI conditioning is concerned. Longevity, we all know, for 4 years to 8 years, gone to 8 to 15 years. Of course, this depends upon number, whether you are pacing, you are sensing, you are doing both, and the number of shocks the patient receives. Bluetooth wireless technology, it's great advance. Previously, we used to give a device, a box to the patient. We used to, the companies to sell that to the patient. It used to remain with the patient. Now, of course, it's inbuilt Bluetooth. So for example, one company, there are several algorithms. One, you have to download the Merlin app on your mobile, and when you say interrogate, the patient has the full interrogation which can be transmitted to you. So now it's really amazing. So the inbuilt Bluetooth technology has simplified the interrogation. Patient doesn't have to come to the hospital, and depending upon the interrogation, then we can advise the patient. So this is an advance. The second is auditory alarms. Previously there used to be all vibratory alarms. Many times the patient during sleep, or we don't used to recognize it. So now you have different types of auditory alarms, different systems in different companies, 4 alarm systems, vibrating modes. But the most important thing is, you must tell the patient that whenever the patient gets an alarm, auditory or vibratory, he has to come for evaluation. If it's a Bluetooth, then you can tell him that you interrogate and send the data. Otherwise, just having an alarm, different systems is no good. You must explain to the patient that he must come for an evaluation. The next are all safety modalities in the later generation devices. Battery assurance alert. That means suppose somebody you check the device, suppose the battery life is say 8 months. Now the new systems have a daily specific drop in voltage measurements. So it gives an alarm when the daily measurements goes beyond a particular limit. So this is something which is new. This is basically for safety, especially in patients where you know now that the battery life is somewhere between 6 months to 1 year. This really helps. The second is long charge time alert. Again, suppose for giving a shock, normally say it's between 5 seconds to 8 seconds, depending upon the company. Suppose it starts getting beyond that, then the alarm is given. This again is helpful whenever the capacitor capacity has gone down, especially at the end of life, anywhere between 6 months to 12 years. So now this long charge time alert tells us that now you have to be, the patient has to be careful. VT assurance, therapy assurance, all these advances are basically to see that the efficacy of the device improves. Now here, whenever there is ventricular fibrillation, sometimes if it is initially the setting was 0.3 millivolts. So if the amplitude is less than 0.3 millivolts, you could have missed, or the device doesn't shock the ventricular fibrillation. But now it has come down to around 0.12. So it almost 99.9% the device will not miss a ventricular fibrillation. So this is called VT therapy assurance. Arrhythmiology, we have three things: SVT discrimination, decreasing inappropriate shocks, and anti-tachycardia pacing. Basically, SVT discriminators basically want to diagnose SVT versus VT so that the patient does not get inappropriate shocks. And for that, there are several modes. Depending upon single and dual, there are various parameters. They look at the stability, the interval stability. It's both in single and dual chambers. If it is onset or a chamber onset, is very helpful in a dual chamber, because if you know for the chamber of onset, you know it is SVT versus VT. Sudden onset is between, for sinus tachycardia is VT, and wavelet or morphology is both in single and dual. And what do? Basically from the onset we try to differentiate whether it's sinus tachycardia versus VT. Stability will differentiate between atrial tachycardia, fibrillations and ventricular tachycardia. So the device looks at several things. As Dr. Nabar said, initially if it's only rate, then it may not be able to differentiate. So from stability to onset to morphology, and of course morphology, that means the basic sinus morphology is stored. And if you find any difference in the morphology, then it says that yes, this is likely to be VT as compared to SVT. So these are the new parameters which have come, and they really help to decrease the inappropriate shocks. And see this, in fact if you see the data, almost 20% are inappropriate. That means 20% of the patients when they had SVT, they were shocked. And this is an important point, that T-wave oversensing and SVT actually account for almost 30% of inappropriate shocks. So all these new generation advances have decreased these particular things. The next, of course, is T-wave discriminators. Now, what they look at is, they of course store the T-wave morphology. Any change in the T-wave morphology, it resets the RR interval. It resets the RR interval, and so what it tries to do is, it tries to decrease the oversensing of it tries to decrease the oversensing of the T-wave, and next one. Okay. So it sort of decreases the inappropriate shock because of T-wave oversensing. Finally, DFT response highlights. You know, initially, if you had somebody who had even a 40 joule did not work, then we had to do several gimmicks with the devices. You know, reverse device polarity, reposition leads, we add SBC coil or remove the SBC coil. Several things we had to really study and do when the threshold was not achieved even with 40 joules. And now, of course, we have DFT response. That means the whole, how you give a shock, the biphasic shock tilt can be changed so that there is improvement in the shock status. So several now advances have come inbuilt, which will actually change the parameters of the biphasic curves, and that will actually decrease. And they try different methods are tried. Programmable shock, they change the shock vectors and see, so that at least, you know, the 40 joules or 30 joules shocks, the patient, it will never happen that the patient gets a ventricular fibrillation and the shock has not terminated the fibrillation. Finally, anti-tachycardia pacing, this is nothing new. But what it has done now is the pain-free trial clearly showed now that almost 70 to 75% of patients can be terminated with a anti-tachycardia pacing. So this is the advance with the different parameters, and that is why today the number of shocks, if you see overall, have decreased significantly with all the forms of anti-tachycardia triad systems we are using. Finally, what are the limitations of all these advances? Number one, for us, we must know it increases the cost. As you go, every advance has its own price. So for us, especially in India, we know we are very cost sensitive. So that is number one. Number two, programming is not simple. You have to do it every day. It's not simple, it's becoming complex. In fact, I always tell this, implantation is a far easier job than programming, and that is why dedicated pacemakers, in fact, if we have taken the statistics in Maharashtra at least, you will find that 90% of it is easier, people implant and forget about it. And that is the problem with dual chamber pacemakers, CRTDs and ICDs. Whenever there is troubleshooting, in fact, you have to sit with the patient, look at the clinical parameters of the patient, see how you can actually manipulate and decrease the clinical symptoms. So this is what I always say about advances, is not just enough having advances. The typical thing in India is that at 1 year, the company person comes to the clinic, he just measures everything, gives you a printout, everybody says it's okay and that's it. So that should be avoided. We should have dedicated pacemaker and ICD clinics where you actually look at the clinical parameters of the patient, look at the advances and try to see that you give the best appropriate parameters to the patient. Futuristic, finally, what about future? Subcutaneous ICD with ATP is almost in phase 4 trials, that the subcutaneous ICD can give ATPs. That will make a lot of difference. I still lead with conduction system pacing. In fact, this will revolutionize if this really comes. That means you put a conduction system pacing, one lead in the atrium, of course, one, and the second one, the conduction pacing, which will defibrillate also. That will really, it's like a CRTD. So that is coming up. And of course, leadless ICD, whether it will come or not, there are some research papers, but this is going to be the future of ICD in the next 5 to 10 years. With this, I think I'll conclude that recent advances, basically we must know that yes, the technology is really progressing. There is one apprenticeship between several companies, but most of them are doing the same work. So it's okay. I mean, you can choose between companies, but most of them are most of them are nearly equal. But with these advances, you must know that interrogation of these pacemakers and actually giving good clinical acumen to what is happening to the patient with these advances, I think that is more important than the advances itself. Thank you very much.